Hello, I'm Dr. Hadley Wilson. I am an interventional cardiologist, Sanger Heart and Vascular Institute in Charlotte, North Carolina, also part of Atrium Advocate Health and professor at Wake Forest University School of Medicine. But also, very importantly to this meeting, past president of the American College of Cardiology. And this is coming from New Orleans on the third day of the ACC 26. I think one of the biggest buzzes was that there was great science here at this meeting. People who really wanted to present to the ACC meeting here. It's the first major meeting of the year. The one was the HI-PEITHO trial, which was looking at ultrasound thrombolytic therapy in high intermediate risk pulmonary embolism. First kind of trial done in over a decade in that area, and was a positive study that showed improved outcomes versus normal anticoagulation for these patients with pulmonary embolism. The other one, though, that maybe a minor surprise was the STEMI door to unloading trial in patients that did not have cardiogenic shock, but was looking to see if using the Impella CP microaxial flow device inserted in patients and delaying opening arteries up to 30 minutes, if that actually improved the myocardial infarct heart attack size. And actually, it did not make a difference. On the other hand, the investigators said, well, we can wait 30 minutes, but if we're unloading the heart, it's the same as if we opened the artery 30 minutes earlier. So maybe there's some kind of signal there to look at trying to use this in a better way in the future to help reduce infarct size. Let's move on to pharmacotherapy. And I think the big picture there was, to me, was that lipid-lowering agents are good. And one was the evolocumab Vesalius trial, essentially looking at high-risk patients with atherosclerosis potential in our diabetic population who did not have previous documented atherosclerosis. So if you treat those with aggressive lipid lowering, like with evolocumab, the PCSK9 inhibitor, does it make a difference? And indeed, they had less events over time, even without having documented coronary atherosclerosis on the front end. But it's logical, but it was great to see that that's proven. Likewise, there was another study about just lipid lowering from the current guideline of LDL less than 70 to less than 55, which is one that's favored in patients who have coronary disease or acute coronary syndrome. This was a large Korean study, and indeed, it showed that further lipid lowering of the LDL to less than 55 did have better outcomes, less coronary atherosclerotic events in this patient population. The discussants really didn't think that for now, since we've just had the primary prevention guidelines come out, that this will necessarily change the guidelines anytime soon. But if we see more like this, that we could see movement towards lower and lower LDL recommendations in the future. There were some good studies also on trying to provide healthy diet DASH type groceries to individuals with hypertension. And indeed, in that population study, those patients that were involved that had these healthy groceries delivered to them, or even given an expense account to buy those groceries themselves, actually did lower their blood pressure and did have better outcomes. So those were just some of the many, I think, interesting themes and studies. But as you can see a lot of this potentially could affect guidelines, certainly helps us with clinical practice, and actually even better that, helps our patient populations when you think about the pharmacotherapy suggestions for lowering cholesterol and improving outcomes.
My name's Luke Laffin, and I'm a preventive cardiologist and cardiovascular clinical trialist at the Cleveland Clinic. At the 2026 ACC Scientific Sessions, I presented the results of the Cardinal trial, which was the investigation of the efficacy and safety of the use of tonlamarsen in the treatment of uncontrolled hypertension. Tonlamarsen is an investigational antisense oligonucleotide. So it's a nucleic acid based therapeutic that's administered every 30 days and suppresses plasma angiotensinogen. The study had three parts to it, essentially. The first was a placebo lead in. And to be eligible for the placebo lead in, you needed to have a GFR over 30. You needed to be taking between 2 and 5 antihypertensives already. And your office systolic blood pressure needed to be between 135 and 170. If after the placebo lead in, 4 weeks later, as an injection of essentially saline, then patients all were enrolled and received a dose of tonlamarsen. Everyone got it, 90 milligrams. And then 4 weeks later, what we did is we randomized participants to ongoing treatment with tonlamarsen every 4 weeks for the subsequent 16 weeks, or to placebo after that initial dose for the subsequent 16 weeks. So the study looked at two co-primary endpoints. The first was looking at changes in serum angiotensinogen from baseline, percentage change, from before the initial injection of tonlamarsen to 20 weeks later. And what we saw in the folks that received ongoing treatment with tonlamarsen was a 67% reduction in angiotensinogen at week 20. What we saw in the participants that were randomized to a single dose of tonlamarsen with subsequent placebo was a little bit unanticipated. We didn't see the angiotensinogen return to baseline. They were 23% suppressed, even 20 weeks after a single injection. And so although there was a significant between treatment group difference, we thought there would be more in that scenario. There's a 44% treatment group difference. The second co-primary endpoint was changes in office systolic blood pressure from prior to that first initial tonlamarsen injection to 20 weeks later. And what we see is both groups had equivalent blood pressure lowering from baseline. Both were just under 7 millimeters of mercury of blood pressure reduction. Okay? And this poses the question, is blood pressure more of a lagging biomarker after that initial deep angiotensinogen suppression? And, we may see blood pressure reduction even as angiotensinogen suppression wanes. We're very excited to soon be launching the Cardinal ASH study, ASH. And ASH stands for acute severe hypertension. So this will enroll participants that were recently hospitalized with either a systolic blood pressure above 180 or a diastolic blood pressure above 110, excuse me. And we think, based on prior clinical evidence, that these patients are most likely to benefit from tonlamarsen because they have overactivity of the renin, angiotensin, aldosterone system. So if we can knock that down with drugs like tonlamarsen for a limited course of time, hopefully we'll lower angiotensinogen again, lower blood pressure, but then also reduce their recurrence of coming back to the hospital or being seen in the emergency department.